Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today I'm talking about blood pressure. And you probably think you know blood pressure, but you don't know blood pressure the way I'm going to teach it to you. So you're going to better understand blood pressure, and you're going to understand why it is part of the vital, as in vital signs. Okay. It's a vital measurement. It's what tells us the person has tendency to stay alive. Okay. So let's study blood pressure. Then we're going to do some NCLEX questions. I think you're going to enjoy this. Hello, Clinic Review family. It's Dr. Sharon from Clinic Reviews, and we are part of the greater Clinic Review organization that offers an online on-demand NCLEX taught by the GOAT himself, Mark Klimek. We also do monthly packages of small group tutoring where you get 4 tutorings, one from me, one from Dr. Pete, and 2 from Mark himself. And then we also have a streaming service that offers a lot of our other videos that we provide, including those here on YouTube. You get them commercial free. You can watch them all as fast as you want to. They're readily available. There's also some there that are not available on YouTube. So it's a low monthly price. So I think you would like that as an option if you're looking for something less expensive. Today I'm talking about blood pressure, and people always think they know blood pressure because we teach it in those intro to nursing classes. Unlicensed assistive personnel can do blood pressures. Really, anybody can do a blood pressure if you can push a button, right? You wrap the cuff around the arm, you push a button, you get a number. You report the number to the nurse and you don't think much about it afterwards. And even the nurse thinks, well, is that normal or is it not normal? And if it's too high, I'll call the doctor and let them decide what to do about it or whatever. And we don't really think much about what it actually means. You've got to understand that the pressure on the inside of first of all, the pressure on the inside of the artery is what is reflected with the blood pressure, right? And if you think about pumping that cuff up, pump that cuff up to 200 millimeters of mercury. Y'all, that hurts. If your blood pressure, if the person's systolic blood pressure is 200 millimeters mercury, that's a heck of a lot of pressure on the inside of that vessel wall, right? And so that's why it can cause damage. And when it causes damage, it causes platelets to aggregate and all kinds of things to come there to try to heal that area. And then it starts to collect, and we start to have atherosclerotic plaque. So that's why high blood pressure is dangerous, because of that really high pressure pounding against the inside of that vessel wall. So that's high blood pressure. But the other thing to remember is that blood moves from areas of high pressure to low pressure. And the venous side, if we think about central venous pressure runs somewhere around 10 millimeters of mercury, somewhere like that. And that means the pressure on the arterial side has to be higher than the venous side. Otherwise, the blood's not going to move into the tissues, right? And you might say, well, gosh, if the mean arterial pressure, I'm going to talk about mean arterial pressure. So let's talk about the average pressure on the arterial side. Let's say it's 70 millimeters of mercury. And on the venous side, it's 10 millimeters of mercury. You say, well, that's a 60 millimeter of mercury difference. Yes, it is. But there has to be at least that much in order to see good tissue perfusion. If you keep getting less and less and less of a difference between the arterial pressure and the venous pressure, and less, you're going to have less and less blood flow. And you have to have a certain amount of blood flow to those tissues to deliver oxygen. I'm just talking faster and faster. I need to slow down. So there's a couple ways that can be a problem. It can be a problem if the arterial pressure drops, or it can be a problem if the venous pressure goes up. How could that venous pressure go up? Well, if you have a lot of venous pooling, blood pooling, like venous stasis, increased venous pressures from increased fluid in the veins, like with heart failure or some other problem, kidney failure. So there's a lot of things that can cause a decrease between the arterial and the venous side. And generally, we try to keep the arterial pressure high enough that we have good supply of blood to the tissues. Remember, blood moves from areas of high pressure to low pressure. And yes, the heart is the engine that pumps it, but the heart has to be able to overcome that arterial pressure, has to be able to overcome it so that it can get out there. And then the arterial pressure has to be high enough to move it. So it's not like there's little soldiers down there carrying the oxygen to the tissues. There's no little soldiers down there, y'all. It's all about pressure balance. That's why I've done a video in the past where I call pressure and perfusion. And it's covering a lot of these same concepts. Today I'm talking about the blue book. There's blood pressure concepts in the blue book. And so there's just factual information you need to know. And I am considering this a blue book lecture, but I'm taking it a little bit farther, not a lot farther, but I'm taking it a little bit farther to help you understand some of these concepts a little bit more in depth. And I've also written NCLEX style questions to go along with it to help you conceptually understand how to take this information and use it. So let's go ahead, first of all, and look at the blood pressure equation. So blood pressure equals cardiac output times systemic vascular resistance. Systemic vascular resistance is the constriction and dilation of the vessel itself. So think about a McDonald's straw, which is a nice fat straw, versus a little coffee stirrer, one of those little red coffee stirrers that you use just to stir up your coffee. Some people drink through them. It is a little tiny straw, but it requires not a lot because it's not hard for us, but it requires more pressure to suck fluid through the coffee stirrer than it does to suck fluid through the McDonald's straw, the big fat straw. And they give you big fat straws, so you'll drink it as fast as you can, right? So that you'll want to get another one. So they give you these straws. It's easier to drink from, but it also, because it requires less effort on our part to suck the fluid through, but it also helps us drink it a little faster so that we can get a refill or whatever we might want to do. So think about the diameter of the coffee stirrer versus the diameter of the McDonald's straw. So the bigger the diameter, the more dilated, the less pressure is inside there. Just like that coffee stirrer requires more pressure to move it through. So the diameter of the vessel itself increases or decreases the pressure. So systemic vascular resistance is all about constriction and dilation. And then, so the equation is blood pressure equals cardiac output times systemic vascular resistance. Well, what is cardiac output? It's heart rate times stroke volume. So that means blood pressure equals heart rate times stroke volume times systemic vascular resistance. What that means for us practically as nurses is that if blood pressure drops and we wanted to get it up, we have three options, and that's it, y'all. We have three options. It's not rocket science. This is not hard to understand. You just have to know what is going on. And so if blood pressure drops and we want to get it up, we can increase heart rate, we can increase stroke volume, we can increase systemic vascular resistance. All right, let's look at the different components of this blood pressure equation specifically. So blood pressure equals heart rate times stroke volume times systemic vascular resistance. What happens if heart rate goes down? Well, if heart rate goes down, theoretically, you should have a decreased blood pressure. It would be called symptomatic bradycardia. This is when we would have to give atropine, right? Because atropine is the drug of choice for symptomatic bradycardia. But whenever you see that your patient is bradycardic, you have to go in and assess their blood pressure before you do anything about it. Okay, so that's the first thing you do. When someone is bradycardic, you check their blood pressure. If it's decreased, if their blood pressure is decreased, you can give atropine. If atropine doesn't work, pretty much we can do a pacemaker or we can do atropine. Those are our two primary things that we can do. Now, what happens if heart rate goes up? Theoretically, it increases blood pressure. So that's why when you're exercising and your heart rate goes up, your blood pressure goes up. Now, if someone is laying in bed and their heart rate goes up for no known reason, like it just goes up to 120, their blood pressure may or may not go up. So a heart rate increase of, say, 20 beats may or may not increase blood pressure. But the question is, what happens if heart rate goes up but stroke volume goes down? So here's the question. So when we're exercising, our heart rate goes up. It may even go up to 160, 170, right? Okay, so maximum is considered 220. So when you think about age-related heart rate, if you want to do it the easy way, it's not perfect, but 220 minus your age is considered your maximal heart rate. Okay, so if you're 40, your maximum should be 180, and you should be exercising to get a good aerobic response. You should be exercising at about 80% of your maximum heart rate. But let's say 180 is your maximum, and it goes up, you're exercising, it goes up to 160, and you're like, well, that's pretty fast. It is pretty fast. It's quite fast, but the reason you're able to still fill, so it has decreased filling time, right? So if your heart rate is this fast, it has that much time for the ventricles to fill, which is stroke volume. But if your heart rate goes up to here, now it has a lot less time to fill. So if you're just laying in bed and your heart rate goes up to 160, 180, you have a lot less time for your ventricles to fill. But if you're exercising, the muscles are pumping. The muscles in your legs are pumping, and they're returning blood to the heart very quickly. It's called the muscle pump. It actually is a real thing, which is why sedentariness increases your risk for DVT, because blood can kind of pool in your extremities if you're not exercising, because it's the muscle pump that encourages blood to return to the heart. All right. So we have this muscle pump, and it increases preload, which then allows the heart to fill very quickly. So when you're exercising, your heart rate can get up that fast, and it doesn't affect cardiac output. In fact, you still have an increased cardiac output when you're exercising. But if you're just laying in bed, not doing anything, someone's just laying there, all of a sudden their heart rate goes up to 160. What happens to the filling of the ventricle? The ventricle doesn't fill nearly as much because there's a lot less time. So what happens to cardiac output? It actually goes down. So there's symptomatic bradycardia. Symptomatic bradycardia is when the heart rate gets too low and the blood pressure drops. There's also symptomatic tachycardia. Usually doesn't occur until over 130 or 140, depending on the age of the patient. Because if you think about it, a 60-year-old's maximum heart rate is 160. An 80-year-old, their maximum age-related heart rate is 140, y'all. So if they get up to 140, 150, 160, and they're 80, y'all, their filling time is just almost nothing. And they're going to have very impaired tissue perfusion because the heart's not pumping much blood out, even though it's beating really, really, really fast. So if they have supraventricular tachycardia, I did a whole video on that not long ago. If they have SVT, if they have AFib with rapid ventricular response, they just don't have a lot of time for that ventricle to fill. And so they're impaired tissue perfusion. They look pale. If they're not perfusing their skin, they're pale. If they're not perfusing their brain, they have a change in level of consciousness. If they're not perfusing their heart, they have chest pain. If they're not perfusing their kidneys, they're having decreased urine output. If they're not perfusing their gut, they have hypoactive bowel sounds. So these are all signs of impaired tissue perfusion. So you can have symptomatic bradycardia. You can also have symptomatic tachycardia. Well, let's look at the stroke volume portion. So when someone's blood pressure starts to drop, the body's immediate response is to increase heart rate. It's a sympathetic nervous system response, and it increases heart rate. And that's the body's response. That's why tachycardia is the earliest sign of a dropping blood pressure, whether it's dropping to the point of shock or it's just a dropping blood pressure. Tachycardia is the earliest sign of that. What do we do then? If someone's blood pressure is dropping and their heart rate is elevated, now we have to take action. Well, what do? Well, we as healthcare workers, we affect stroke volume. And the way we affect stroke volume is by increasing overall volume. So we give fluids. You ever given a fluid bolus, a saline fluid bolus? You hang a 1,000 ml bag and you give it over an hour because their blood pressure is dropping, right? So we know that if we give fluids, that increases volume, which increases stroke volume, which increases blood pressure. And that's why that's the first intervention that we always use when someone has a dropping blood pressure. Now, if we want to decrease blood pressure, we can decrease stroke volume. Well, how do we decrease volume, y'all? We give diuretics, right? So sometimes that's why diuretics are used to treat blood pressure or to decrease blood pressure. Okay, let's talk about systemic vascular resistance. So we've got increased, just so you know, you have to understand conceptually, increased SVR is vasoconstriction, which means it's the vessel's getting smaller, because when the vessel gets smaller, that increases pressure inside of it. So if you decrease SVR, that's dilation. So dilation decreases the pressure because it's a wider vessel. So that means increased SVRs, which is constriction, increases blood pressure. Decreased SVR, which is dilation, is decreased blood pressure. So if it helps you to remember decreased SVR is dilation, decreased is dilation, that might help you. I don't know, but you do have to remember that constriction is increasing SVR and dilation is decreasing SVR. Now, we can give meds that can vasodilate and we can give meds that can vasoconstrict. And a lot of the blood pressure meds we give vasodilate, right? We can give a direct vasodilator, for example. Hydralazine is a direct vasodilator. That's one of the medications that we often give IV to try to get blood pressure down kind of quickly, and that will vasodilate. We also give what are called vasopressors that vasoconstrict when someone's is in shock or they've been in shock. We can't get their blood. We've given them tons of fluids. We can't get their blood pressure up, so we put them on a vasopressor, like norepinephrine. It's called, the trade name is Levofed, or one of the trade names is Levofed. You can give norepinephrine. That's a vasopressor, but y'all, you have to be careful. Do not willy-nilly be putting people on vasopressors. If you vasoconstrict, I want you to imagine what happens to the perfusion of the toes and the fingers and the nose and the ears. Because when you vasoconstrict, you're vasoconstricting for the purpose of enhancing tissue perfusion, but you're enhancing tissue perfusion to the vital organs. You're actually decreasing perfusion to the fingers, the toes, the ears, the nose, which is why when people are on long-term vasopressors, they can start to get necrosis in their ears, necrose their nose, necrose their fingers, necrose their toes. And if they stay on vasopressors long enough, sometimes their kidneys actually start to fail and some other things. So vasopressors, which are vasoconstrictors, they increase SVR, which increases blood pressure, have some pretty significant side effects. So let's talk about how we can, or not how we, but how can heart rate be increased? Well, the number one way heart rates increase is a sympathetic response. Our sympathetic nervous system releases the neurotransmitters to increase heart rate. That's our body's first response. We can also give atropine. If they have symptomatic bradycardia, we can give atropine to increase heart rate. Now, decreasing heart rate, we often want to decrease heart rate. Beta blockers, metoprolol, propranolol, carvedilol, these are all beta blockers that decrease heart rate. Calcium channel blockers like amlodipine, cardizem, diltiazem, these things can decrease heart rate. And then we can just have people rest. So if they get up and walk to the bathroom, I'm talking from a nursing perspective, y'all, if they get up and walk to the bathroom, they're tachycardic and symptomatically tachycardic, just have them sit down and rest, right? And get that heart rate down. So that's often the first thing that we do. We can also, I didn't put it on here, but we can do the Valsalva maneuver. Do you know what the Valsalva maneuver is? Right? You're pushing, you're bearing down. Okay. That can also decrease heart rate sometimes. Doesn't always work, but it can work. All right. How do we increase stroke volume? We can increasing preload by doing the muscle pump. So exercise increases stroke volume. We can give digoxin. Digoxin increases the force of contraction. It's an inotropic agent. Dobutamine is an inotropic agent, so it can increase force of contraction. And milrinone is an inotropic agent. The most common way, though, that we increase stroke volume is by increasing volume in general. So we just give them fluids, right? Give them saline, could give them LR, but most often we give them saline. And we just increase volume. And we say, I hope it doesn't fluid volume overload them, because if it fluid volume overloads them, then we're going to have to decrease volume. Okay, so how can we decrease stroke volume? We can decrease stroke volume by decreasing volume or by decreasing the force of contraction. We don't really want to decrease the force of contraction, but sometimes it happens. Beta blockers don't just decrease heart rate, y'all. They decrease force of contraction, which is why we have to use beta blockers very carefully with heart failure. With heart failure, we want to decrease the work of the heart. We want to decrease the overall oxygen demand of the heart with heart failure. And we can give a beta blocker to slow heart rate, which decreases the overall work of the heart. It's a good thing. Beta blockers are good for the heart. But we have to be careful if they have heart failure, because it can also decrease force of contraction. And carvedilol, this is important for you to know, carvedilol is the only beta blocker that can be given with heart failure patients. All the other beta blockers can be given to reduce heart rate or to reduce blood pressure by reducing heart rate, and also by reducing stroke volume. But carvedilol is the only one we can also give with heart failure. Diuretics reduce stroke volume by getting rid of overall volume. We can decrease preload. How can we decrease preload? Well, rest will decrease preload because you don't have the muscle pump. But nitroglycerin, when someone's having chest pain, right? And we give them nitroglycerin, sublingual, nitroglycerin does vasodilate the coronary arteries. But do you know what it does more than anything? It causes venous vasodilation. When you have venous vasodilation, you decrease preload, you decrease the blood return to the heart. So do you know what the number one way that nitroglycerin works to decrease chest pain is? Y'all, it decreases preload, which decreases stroke volume, which decreases oxygen demand. When you decrease oxygen demand, someone's having angina. I'm having the pain in my heart, Hazel, I think I'm dying, right? And we're like, oh no, give them some nitroglycerin, decrease that angina. We're decreasing oxygen demand. One of the best ways to do that is to decrease preload. because increased preload increases the oxygen demand of the heart. Nitroglycerin does that very well. It also decreases or it also causes arterial dilation, but primarily it decreases preload. Do you know why blood pressure drops so much after you give nitroglycerin? Because it decreases preload, y'all. Decreases stroke volume, and the blood pressure goes way down. It's not a diuretic. It just decreases preload. It causes venous vasodilation. I just think that's super interesting. That's why I keep talking about it. All right, let's talk about systemic vascular resistance. This is the constriction or dilation of the peripheral vessels. So how can we increase SVR? Well, there's vasoconstriction occurs with the sympathetic nervous system. So the sympathetic nervous system can cause vasoconstriction. We can also give vasopressors. This is when I told you, be very careful about giving vasopressors like norepinephrine and dopamine. These are drugs that cause vasoconstriction. They're vasopressors. Be very careful about them. They'd be in the ICU on a drip of these medications. Now, if we want to decrease SVR, we want to cause vasodilation. The parasympathetic nervous system can cause vasodilation. This is why people who are they exercise regularly, like they run regularly. Not only do they have a low heart rate, they have a low blood pressure. And they have a low blood pressure not just because they have a low heart rate, but because they have increased parasympathetic tone and they have a lot more vasodilation. And then hydralazine is a drug that is a direct vasodilator. Nitroglycerin is a drug that will vasodilate. What about all these other blood pressure meds? Well, other blood pressure meds, I talked about beta blockers. Then we have ACE inhibitors, angiotensin converting enzyme inhibitors. ACE inhibitors cause vasodilation, but it's in an indirect way that it does that. So we do have vasodilation with ACE inhibitors. Angiotensin receptor blockers, ARBs, also cause vasodilation, but it's very indirect. It's by blocking constriction. So ACE inhibitors and ARBs block vasoconstriction. They don't actually cause dilation so much as they block constriction. So that's why you don't see the big drops in blood pressure with ACE inhibitors and ARBs that you can see with diuretics, that you can see with hydralazine, that you can see with nitroglycerin, because hydralazine and nitroglycerin are direct vasodilators. And you can see a big drop in blood pressure with those. All right, let's just talk about some words you need to know. Systole is the contraction of the heart. Diastole is when the heart is at rest. So systole is the contraction. Diastole is when the heart is at rest. Cardiac cycle is one systole and one diastole. So contraction, rest, contraction, rest, contraction, rest. That's one cardiac cycle. Now, when you're listening, you're actually listening to you're putting your stethoscope over the brachial artery and you're listening for the sound. The systolic sound is the very first sound that you hear, and it's usually really faint, like ch, ch, ch. It's not real loud. It's real faint. You go, okay, that's the first sound. That's the systolic number. And then you listen, it gets louder, ch, 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 and then it starts to get quieter again. The very last sound you hear is the diastolic number. The very last one. Not the change in sound, but the very last sound. So the first sound you hear is systolic. The last sound you hear is the diastolic. And what happens is when you put that cuff and you wrap that cuff around the arm, you pump it up until it completely compresses that vessel, y'all. There's no blood getting through there. That's why it hurts so much. There's no blood getting through the brachial artery. And you put your stethoscope here and you start to let it off. And what happens is the pressure on the inside of the vessel with systole, with contraction, the pressure on the inside of the vessel is greater than the pressure on the outside. So you get it down to where the pressure on the outside is, say, 120 millimeters of mercury. That pressure is just less than the systolic pressure. And so you hear just a little bit of blood gets through there, just a little bit. It's real quiet. And then you start to let it off and it becomes less and less compressed. It starts to open up more and more. So initially it was sort of like this. So you get it starts to get quiet again because it's almost all the way open. And then by the time it gets all the way open, you don't hear anything. And that tells you that's the diastolic number. That's the lowest pressure in the vessel when the heart is at rest. The highest pressure when the heart is contracting, the lowest pressure when the heart is at complete rest. And so we get the systolic and the diastolic. Now there's an average mean arterial pressure, the average pressure. So if the systolic is 120 and the diastolic is, say, 60, so 120 over 60, the mean arterial pressure is actually systolic plus diastolic times 2 divided by 3. So we have the diastolic blood pressure is 2/3 of the cardiac cycle. Remember, a cardiac cycle is systole and diastole. But the diastolic, the time the heart is at rest, is twice as long as it's contracting. So we have to go systolic plus diastolic times 2 divided by 3. So if we want to figure out mean arterial pressure, let's say 120 over 60. Say their blood pressure is 120 over 60. I'm going to open up my calculator because I can't do it any other way. Okay. So I'm going to say 120 plus 60 plus 60. So 120 plus 60 is 240 divided by 3. So the mean arterial pressure is 80. Someone's blood pressure is 120 over 60. Their mean arterial pressure is 80. Let's say their blood pressure is 110 over 70. 110 over 70. Go ahead and measure their mean arterial pressure. Their blood pressure is 110 over 70. That's 110 plus 70 plus 70. You should have gotten 250. Divide that by 3. Imagine that. The blood pressure at 110 over 70, the mean arterial pressure is higher than when the blood pressure is 120 over 60. Because when it's 120 over 60, the mean arterial pressure is 80. But when it's 110 over 70, the mean arterial pressure is 83. And that's because the diastolic is 2/3 of the cardiac cycle. So if we have to calculate the diastolic twice, the diastolic pressure has a greater influence on mean arterial pressure that the systolic pressure does. Okay, what happens to blood pressure if the cuff is too small? You just memorize it. The cuff is too small, the pressure is falsely high. If the cuff is too big, the pressure is falsely low. All right, what's pulse pressure? Pulse pressure is the difference between the systolic and the diastolic. It's difference between the systolic and the diastolic. So if the systolic is 120 and the diastolic is 60, the pulse pressure is 60. Because 120 minus 60 is 60. What's the pulse pressure if the blood pressure is 110 over 70? Well, 110 minus 70 is 40. So the pulse pressure is 40. So if the pulse pressure is 60, that's a wider pulse pressure than a pulse pressure of 40. 40 is a narrower pulse pressure than 60. Now, there's no exact pulse pressure that's best, but you should keep an eye on whether the pulse pressure widens or narrows, because with shock, the pulse pressure narrows. With increased intracranial pressure, the pulse pressure widens. You could get a question like that, especially about increased intracranial pressure. They could ask you a question about what makes you think their intracranial pressure is going up. And the answer is they have a widening pulse pressure. So if their pulse is, or if their blood pressure is 110 over 70, which is a pulse pressure of 40, and then their blood pressure goes to 130 over 40, what's the pulse pressure there? Well, that's 60, 70, 80, 90. That's a widening pulse pressure. And I'd go, I think their intracranial pressure is going up. Now, that's not the only reason that you have an increased, that you have a widened pulse pressure. But I'm saying if they give you a scenario where they tell you you're monitoring for increased intracranial pressure, that's the scenario. And they say, how are you going to know if the intracranial pressure is going up? Well, it could be a headache, certainly, but you could also monitor for a widening pulse pressure. How do you know they're going into shock? They may be still alert and oriented and talking to you. How do you know they could be going into shock? Well, maybe their blood pressure went from 100 over 60 to 90 over 70. So 100 over 60, let's think about this. 100 over 60. That's 100 plus 60 plus 60. So that's 220 divided by 3. So the mean arterial pressure is 73. For a blood pressure of 100 over 60, the mean arterial pressure is 73. Well, what happens if it drops to 90 over 70? Well, that's 90 plus 70 plus 70. 230 divided by 3. Now the mean arterial pressure is 76. Do you know that the map went up? The map went up. They're going into shock and their map went up. Do you know why their map went up? Because the body, the sympathetic nervous system, is stimulating vasoconstriction. And so even though they're going into shock, the body's trying to compensate for that by vasoconstricting. So maybe they're going into hypovolemic shock and they're losing blood, but they're vasoconstricting. So the systolic pressure goes down, but the diastolic pressure actually goes up to try to compensate for that because of the vasoconstriction. So whether you remember that or not is up to you. But I'm telling you, pulse pressure, it could on the test and in real life, pulse pressure does make a difference, y'all. All right, let's do some questions to see if we can apply some of what we just talked about. A client's blood pressure is 120/80. What is the client's mean arterial pressure? Well, you know it's not 70 because it cannot be lower than the diastolic pressure. The MAP cannot be lower than the diastolic pressure, okay? So what is the mean arterial pressure? Well, 120 plus 80 plus 80. So 120 plus 160 is 280. So divide that by 3. And you get 93. Now you might go, well, Sharon, the 93 is not there. Okay, then pick the one that's closest to it. Okay, so 90. We're going to pick 90. If they ask you to write it in, which they won't ask you to do that. If they ask you to write it in, write in 93. That's fine. The nurse knows that mean arterial pressure is important because it reflects the perfusion pressure seen by the organs. Remember, I told you the blood flows from areas of high pressure to low. So you have to have a certain difference between the arterial and the venous side. Remember, the venous side runs around 10 millimeters of mercury. So we need to maintain a certain difference so that you can have good, not just barely adequate, but good perfusion. So what is the minimal MAP required to maintain adequate perfusion to the vital organs? The minimal MAP is 60. Now, if you're like me, where at my college where I teach, we teach 65. And I intentionally put 60 here so that you know that 65 and 60 are sort of similar. So if you learn 65, then, but 65 is not an option, go with 60. Don't pick 70 because that's really higher than what you need. And the question says minimal. So if it's asking minimal, don't go higher than you need. If you're like, well, I learned 65, well, then choose 60 because many, many places say 60 is adequate. And I don't know why at our college we teach 65. I think that's just a college preference. I don't think that's a universal mandate. Okay. So 60 is what I've been most familiar with. So if you learn 65, that's fine. You use 65 on your tests, but on the NCLEX and in real life, you're probably going to go with 60. Which condition would most likely result in a widened pulse pressure? Hypovolemic shock. Hypovolemic shock is going to cause a narrowed pulse pressure. Aortic regurgitation. All right, aortic regurgitation. What you're going to see is you're going to see the typical amount of blood be pushed out. So you're going to get the same systolic pressure, but then some of that blood is going to regurgitate back. So you could end up with a lower diastolic. So with aortic regurgitation, you're going to see the same systolic, but a lower diastolic, which means it's a widened pulse pressure. Okay, so it could be that. Cardiac tamponade. Cardiac tamponade is where the heart is, there's inflammation around the heart, and it makes it harder for the heart to beat. So you actually see a decreased pulse pressure, a narrower pulse pressure, and a lower blood pressure in general. And heart failure, you see a drop in blood pressure in general. So aortic regurgitation is the answer. Now, I didn't tell you aortic regurgitation resulted in a widened pulse pressure. I wanted to just talk through why that is so you can conceptually think through why things might happen. Okay, so the next few questions are going to seem a little confusing to you because the NCLEX is not really going to ask you whether what happens between the systolic and the diastolic so much. They may ask you about widening or narrowed pulse pressure, but they're not so much going to say increasing this, decreasing this, probably. But I want to show you how you can figure out the answers. The right answers are the right answers because of the other answers. Okay? Because sometimes these answers are going to be different, not conceptually different, but they're going to be different words, but they're still both right because the other answers are wrong. So which blood pressure change is most commonly associated with hypovolemic shock? Hypovolemic shock. So the most commonly associated pressure change with hypovolemic shock is a drop in blood pressure. Okay, think about it. Hypertension. No. Widened pulse pressure with hypertension. No. Hypertension is out. Hypertension with bradycardia. No. Hypertension is out. Narrow pulse pressure with hypotension. Well, here we have hypotension. And does a narrow pulse pressure make sense? It makes sense early on because when you have a decreased volume, you're going to see a response of vasoconstriction. So you're going to see increased SVR in response to decreased volume. So you could see a narrowed pulse pressure early on. It's probably not going to last long, but you're going to see a narrowed pulse pressure early on. So the only right answer here, because all the other answers are clearly wrong, the only right answer here is D. A client's heart rate decreases significantly. What effect would the nurse expect this to have on the client's blood pressure? I'd expect it to decrease blood pressure. Okay, heart rate goes down, blood pressure goes down. So decreased systolic blood pressure, yes. Increased systolic and diastolic pressure, no. No change in blood pressure, no. Widened pulse pressure, no. The only one that says decreased blood pressure is A, right? Widened pulse pressure isn't a decreased blood pressure. It's an increased systolic and a decreased diastolic. But I don't expect that when the heart rate goes down. I certainly don't expect a widened pulse pressure. So the only answer that makes sense here is A. A client experiences tachycardia with a heart rate of 150. What is the most likely effect on blood pressure? Well, I told you if it goes, it doesn't say they're exercising. So don't go, well, they could be exercising. They're not exercising, or they would tell you that. So when someone becomes symptomatically tachycardic, it's because they have a drop in stroke volume. And remember, when someone is symptomatically tachycardic, what happens to blood pressure? Once it's over 130, 140, they're symptomatically tachycardic, blood pressure goes down. So that's what I'm looking for. Increased systolic pressure, no. Decreased diastolic pressure. I like this one. A client has significant blood loss following surgery. What change in blood pressure would the nurse expect? Well, if you lose blood, you lose volume. Loss of volume equals drop in blood pressure, right? All right. Increased systolic and diastolic. No, we're not going up. We're dropping. Decreased systolic and diastolic. Sure, yeah. Increased systolic and decreased diastolic. No, that's a widening pulse pressure. Absolutely not. Increased diastolic pressure. No. The only one that makes any sense, because I know blood pressure should go down, is B. A nurse is caring for a client with an increase in SVR. Remember, SVR is the third component of the blood pressure equation. So when SVR goes up, blood pressure goes up. What effect would this have on the client's blood pressure? Decreased systolic pressure? No. Increased diastolic pressure? Yeah. I'd expect if SVR goes up, I'd expect diastolic to go up. Decreased diastolic pressure? No. Decreased MAP? No. The only one that says increased pressure, even though it only says diastolic, the only one that says increased pressure, y'all, is B. A client with septic shock has a decrease in SVR. What would this effect be on the client's blood pressure? Well, SVR is one of the three components of the blood pressure equation. When SVR goes down, blood pressure goes down. All right, decreased systolic and diastolic. Sure, yeah, that's down blood pressure. Increased systolic and diastolic. No, increased systolic only. No reason to think it would only be that. Or I'm sorry, increased systolic pressure only. No, we're looking for decrease. No significant change. No. Decreased. The only one that says decreased is A. Client with heart failure has a decrease in stroke volume. How would this affect client's blood pressure? Y'all, stroke volume is one of the three parts of the equation. You want to look for a drop in blood pressure, increased systolic and decreased diastolic. No, we're not going to get an increased systolic for sure when you have a drop in volume. Increased systolic pressure only. Well, that basically says the same thing as A. No. No change in blood pressure. No. Decreased systolic and diastolic. Yes. Okay. So, and you might say, but Sharon, that contradicts what we chose in other questions. No, it doesn't. The right answer is the right answer because of the other answers. You have to look at the answers that are available to you and say which one makes the most sense conceptually with what I have learned about how blood pressure reacts to these different changes in heart rate, stroke volume, and vascular resistance. A client is being treated for hypertension, is on vasodilator therapy. What change in blood pressure is expected? Well, vasodilation is a drop in SVR, which is a drop in blood pressure. So we're looking for a down blood pressure. Decreased systolic and diastolic. Yeah, vasodilation, decreased blood pressure. Absolutely. B, increased systolic and decreased diastolic. No, we're not going to see an increased systolic. C, increased diastolic pressure only. No significant change. No, we're giving it to them to drop their blood pressure, y'all. So again, don't say, Sharon, this is different than other answers. No, it's not. The right answer is the right answer because of the other answers. This is the only one that makes sense in this context of these 4 questions. A is the only one that makes any sense here. Okay, y'all, I mismarked the right answer on this one, okay? And so I'm going to explain it to you because we're going to figure out what the right answer is, and then we're going to see that I marked the wrong answer. I marked the right answer incorrectly, so don't let it confuse you. A nurse is monitoring a client with increased preload. What is the expected effect on blood pressure? Y'all, increased preload. That's that muscle pump that pumps blood back to the heart. It increases venous return to the heart, increased preload. That increases stroke volume. So if you increase stroke volume, what's going to happen to blood pressure? It's going to go up. Decrease systolic, diastolic pressure. No, we want it to go up. Increase systolic and diastolic pressure. Yes. Decrease diastolic pressure with increased systolic pressure. There's no reason to think there's no reason diastolic pressure would go down with an increased preload. That doesn't even make sense. No change in blood pressure. No. Y'all, the right answer is B. Listen, the right answer is B. I mismarked it. Ignore that. The right answer was B. A client with severe dehydration has a significant drop in blood pressure upon standing. This is best described as what? Either you know it or you don't know it. Drop in blood pressure. And it has to be 20 millimeters of mercury, by the way. 20 millimeters of mercury drop is orthostatic hypotension. Okay, that may have been a bit challenging for you. And it was a bit challenging for me to record, actually. And for me to figure out how I wanted to teach this information to you without confusing you. So I hope it was helpful. I hope you better understand blood pressure, and I hope you better understand choosing the right answer because of the other answers. So when you do NCLEX questions, it's not your goal to memorize the right answer for the NCLEX question. Your goal is to read the answers and think conceptually and say, which is the answer that is most consistent with what I know is happening here. Okay, that's the thing you have to remember. And I am just as likely to think somebody's trying to trick me. When I do NCLEX questions, like I go to official books and databases, are they trying to trick me? They're not trying to trick you, y'all. I'm not trying to trick you. Okay, you need to think conceptually, use your common sense, don't overthink, don't add a bunch of scenarios to it. They could be exercising. They're not exercising if they don't tell you they're exercising. Okay, so I hope this was helpful, and I'll see you later. Have a great rest of your day.